Good evening, guys. I have discussion C for you. Now we're discussing bipolar disorder significantly increases the likelihood of developing four major co-occurring mental health conditions. Okay, so that is what C is going to cover for you all. So let's dig into it now, please. All right, bipolar disorder significantly increases the likelihood of developing four major co-occurring mental health conditions: substance use disorders, anxiety disorders, obsessive compulsive disorder, OCD, and attention deficit hyperactivity disorder. What the study and clinical reviews show: research on psychiatric comorbidities in bipolar disorder consistently finds that people with bipolar disorder face a much higher risk of developing additional mental health conditions. These comorbidities often worsen symptoms, complicate treatment, and increase hospitalizations. Below is a clear breakdown of the four key mental health conditions most strongly most strongly linked to bipolar disorder based on the scientific sources uh, retrieved. 1. Substance use disorder, or SUDs. Most common comorbidity: over half of individuals with bipolar disorder develop a substance use disorder at some points. Alcohol use disorder is the most prevalent, but cannabis and other drugs are also common. Shared genetic factors and overlapping brain pathways related to impulsivity and reward. Many explain the strong link. Substance use often worsens mood, in, instability, and increases relapse risk. Anxiety, anxiety disorders. Roughly 40% of people with bipolar disorder also receive an anxiety disorder diagnosis. Generalized anxiety disorder is especially common. Anxiety can precede uh, bipolar disorder in some individuals, and many worsen the course of illness, reduce treatment responses, and increase severity. Clinical reviews emphasize the need for careful assessment because anxiety symptoms can mimic or mask bipolar symptoms. Obsessive compulsive disorder, or OCD. OCD is recognized psychiatric comorbidity in bipolar disorder. When present, it can complicate diagnosis because intuitive intrusive thoughts and compulsive behaviors may overlap with depressive or mixed states. OCD symptoms often fluctuate with mood episodes, making treatment more complex. Attention deficit hyperactivity disorder, or ADHD. ADHD frequently co-occurs with bipolar disorder, especially in individuals whose symptoms begin in childhood or adolescence. Symptoms overlap, such as impulsivity, uh, distractibility, and restlessness, can delay adequate diagnosis. Co occurring ADHD is associated with more severe mood episodes and higher risks of substance use. Why these comorbidities matter. Each additional condition increases clinical complexity, making treatment more challenging. Comorbidities are linked to higher hospitalization rates, poorer functioning, and greater symptom burden. Integrated treatment addressing mood, symptoms, and co-occurring disorders is essential for better outcomes. Bottom line, the scientific literature is clear. Bipolar disorder is strongly associated with elevated risks of or for substance use disorders, anxiety disorders, OCD, and ADHD. These comorbidities are common, clinically significant, and require coordinated, individualized treatment approaches. Bipolar disorder commonly co-occurs with anxiety disorders, which are present in roughly half of people with bipolar disorder and are associated with earlier onset, a worse course, and treatment, complications, careful assessment, and integrated treatment favoring psychotherapy like CBT and cautious use of antidepressants are, are essential. This comprehensive review synthesizes uh, epidemiology, prognosis, and treatment. evidence on comorbid anxiety in bipolar disorder or BD. It finds high lifetime prevalence, frequent diagnostic overlap, evidence that anxiety can precede BD in some high risk people, and clear negative effects on illness course and treatment response. Key findings: prevalence, meta analysis, and reviews estimate that about 40 to 45% of people with BD have had at least one lifetime anxiety disorder with substantial heterogeneous across studies. Temporal relationship. Anxiety disorders often precede mood episodes in a subset of patients, suggesting anxiety can be an early marker of risk for later BD. Prognosis. Comorbid anxiety is linked to more severe mood episodes, reduced time well, less higher higher relapses and hospitalizations, raises and poorer functional outcomes. Specific anxiety disorders: panic disorder, social anxiety or GAD, PTSD, and OCD are all overrepresented in BD. Panic disorder in BD shows elevated lifetime prevalence and is associated with increased suicide behavior and chronicity. Treatment implications and recommendations. Assessment: routinely screen for current and lifetime anxiety disorders in all patients with BD because symptoms often overlap and can be masked by mood states. Medication caution: antidepressants can destabilize mood in some people. With BD. So clinicians should use them cautiously, usually only with a mood stabilizer and close monitoring. Psychotherapy, cognitive behavioral therapy, and anxiety focused psychotherapies show promise as first line or adjunctive treatments because they target anxiety without pharmacological mood stabilizers. Risks: integrated care. Treat mood stabilization and anxiety. Concurrently, address substance use, sleep, and psychosocial stressors that amplify both conditions. Practical guide for clinicians and patients. Key considerations: establish mood stability baseline before treating anxiety aggressively. Document lifetime anxiety history. Prioritize therapies with low risk mood switching. Important. Uh, Monitor for emergence mania. Okay, guys, that is your C for this afternoon. Um, I will try and jump back on later. For now, Gator Wellness, take care, folks.